Hi, so Dr. Kenneth Hughes here discussing a little bit about Brazilian buttlift. Brazilian buttlift is, at its simplest form, liposuction of the various areas of the body, whether that be abdomen, sides, lower back, upper back, bra roll, posterior axilla, anterior axilla, arms, inner thighs, outer thighs, even calves and ankles, chin. Obviously, those latter areas don't contribute a lot to the total fatty amount, but liposuction of those areas can all be performed because they have subcutaneous layers that are amenable to liposuction. And then what you're doing is you're taking that fat that you have then harvested and then placing that into other areas of the body. And in this case, for the Brazilian butt lift, you're placing it into the buttock and into the hips, usually to improve the buttock projection, the roundness, sometimes symmetry, and also to improve the hourglass figure. So you're working in conjunction with both the liposuction and the transfer to kind of alter certain proportions to optimize patient outcome, patient body shapes. So for instance, let's say you're talking about liposuction of the abdomen, the sides, the lower back. Those three areas basically encompass a circumferential liposuction that is reducing the weight to its maximal extent. And thus, by doing that, you're setting the patient up to have, the smallest waist with potentially the best waist to hip ratio, okay? And so you can optimize the hip, obviously, by transferring fat into the hip, and then obviously the waist to hip ratio is further improved. With regard to the buttock, if you think about it, liposuction of the lower back and sometimes the posterior thigh can absolutely improve the buttock projection or give the appearance of improvement of buttock projection. That's very important. Some patients don't really have any buttock projection whatsoever, and so you really need to work extremely hard to liposuction those areas because, quite frankly, the liposuction is far more predictable in the result than is the fat transfer to the buttock and the hips. Okay, fat transfer depends upon fat, which is an intrinsically weak substance, to kind of create some kind of leverage on a skin envelope that may be extremely static, okay? It may not want to expand at all, and so sometimes the fat transfer results are less than impressive. It has nothing to do with the technical aspects of the surgery or the prowess of the surgeon, okay? If you go up against a brick wall with a fat container, the brick wall is going to win every time, okay? It doesn't matter who's throwing the fat at the brick wall, okay? And it's the same concept, okay? So while the skin may not be a brick wall, in patients who have had previous surgery, who have a lot of scar, who have some kind of intrinsic dent due to congenital anomaly or traumatic deformity, those patients are always going to be much more difficult to expand. So liposuction is a far more predictable modality than is the fat transfer, okay? That's very important to remember in some of these patients who want the Brazilian butt lift and who have certain types of ideas of how large their buttock can be or how great their hips can expand. And this is important in maintaining realistic expectations. And patients, I always tell patients the same thing about this so that they understand, hey, it's not Dr. Hughes that he forgot or he doesn't know what's going on. I can transfer that fat basically millimeter by millimeter into any little substance you want. But if this substance doesn't expand, if that envelope doesn't expand, adding additional fat is only going to increase risk of infection and fat necrosis, okay? So it doesn't make any sense to do that. I'm not helping the patient by doing that. I'm increasing their risks, their complications. Now, when you're doing the Brazilian butt lift, a lot of people will ask me, well, can you do it under local? Well, sure, you can do anything under local, and ideally, I would like to do the procedures under local because the patient's awake, you minimize the risk for blood clots, you minimize any kind of intubation risk, esophageal perforation, collapsed lung, atelectasis, prolonged recovery. Sometimes people have other problems with the anesthetic, okay? Maybe there's some kind of reaction to various medications. Sometimes they're asthmatic kind of people who are prone to asthmatic attacks or something of that nature. Basically, any kind of tube substance put into that area, okay, into the airway can basically activate those symptoms, okay? And so sometimes you can bring on somebody who has maybe a latent form of asthma or something that isn't as well managed and kind of bring that out. So there are literally thousands of things that general anesthesia can induce or can create additional problems for you, and you want to try to avoid that. However, having said all of that and the fact that I would love to do everything under local, patients have certain pain tolerance limitations, okay? So if you're liposuctioning a person's abdomen, for instance, I consider that one area. Now, liposuction of the abdomen is a pretty good surface area, and the way I would look at it is if you're liposuctioning a surface area that's much larger than, maybe a hand breadth, you probably need more anesthesia, okay? And the reason for that is you can never totally numb a person's subcutaneous tissues, okay? There are little perforators in there, and there are little, all of the vasculature carries kind of these little nervous bundles as well, okay, that are autoregulatory in nature. But there are just so many of these little nervelets. I like to call them nervelets. That's obviously not what they're called, but they're small. But still, every time you hit those, you're going to create, pain, and that patient will experience that as pain. So even though you put in the numbing medication, it never fully blocks all of those, and you're always going to feel some of that. And although you can wait and sit there, almost always patients will have some kind of negative response to a large surface area of liposuction. Now, some people can tolerate that fine because they have the ability to kind of think to themselves, hey, this is just a fleeting, ephemeral thing, and I'm going to get a long-term result, and I can sit here and stick this out, even if it does hurt some, okay? Now, but that's certainly in most of the people, okay? So I'm very wary of starting a procedure on a person for multiple areas of liposuction, hoping they can get through it, okay? It's much better to go ahead and plan for a general anesthesia on multiple areas so that the patient can get the optimal result. Because another thing people don't realize is you don't want to be a surgeon stopping the surgery in the middle because a person experiences pain. Pain shouldn't be the limiting factor in optimizing a surgical result. So when you're considering liposuction under local versus liposuction under general, if you're doing more than one area, I say go ahead and do the general, okay? Because you want me to harvest as much fat as possible and to not stop and to create everything as smoothly as possible. And if you run into a particular area that hurts a person more than another, and inevitably that's the case, you'll run into one little area, no matter how much numbing medication you put in, the patient will continue to experience that as painful. That means that you're going to have to lay off that one area, and that may lead to a lumpy appearance or something that isn't quite as smooth as it could have been otherwise. So that's why, unless it's some kind of small area, confined area, smaller surface area surgeries, or someone can tolerate, go with the general, okay? Now, having said that, when you're under general, you shouldn't be lollygagging around trying to do 6-8 hour liposuctions. All these liposuctions that I do, even for multiple areas, I'm finished in under 2 hours, okay? So you need to be efficient at doing these because the risks go up under general anesthesia. So all these things play into your head when you're calculating, what are the best risk-benefit ratios for the patient. So if I'm doing liposuction, I'm doing a transfer like the Brazilian butt lift, okay? The fat transfer with, let's say, liposuction of the abdomen, the sides, the lower back, the bra roll, that usually takes me about 2 hours. It may take a little less, a little more, depending upon the fibrous nature of the fat, whether a person's had surgery before. Most of my patients have had surgery before. I'm performing the revision. So usually there's more scar tissue that leads to a longer surgery. So patients should always be aware of that there can be variation in that. And sometimes it's hilarious because that always ends up causing the second or the third patient to be upset because we're doing averages. And let's say a person has a particularly unfavorable abdominal scar or scarring kind of conformation, then you're not going to finish that surgery in time. Or if the anesthesiologist can't find the vein as quickly as possible, I mean, sometimes it takes an hour to find a vein, okay? That's not the, that's not the usual, but obviously that puts your schedule back an hour, and then the next patient says, well, Dr. Hughes was late. Dr. Hughes isn't late. Dr. Hughes is usually the victim of some other circumstances, and most of the time, the reason why Dr. Hughes is late is because the first patient just shows up an hour late and says it was traffic when they really just got up an hour late and just have no respect for my time. So realize that and try to be a little bit more understanding when I'm, trying to give you the best result. So back to the general versus the local, okay? So general, you also have to realize that when you're putting in local, it occupies a volume, okay? The local itself. So if you're trying to maximize fatty transfer to the buttock and the hips, why do you want to put in something that occupies volume, okay? Because inevitably that is going to take up some of the space into which you could inject the fat, okay? So that's another reason to back down on this kind of hyper-aggressiveness towards the local, or the dogmatism that I see on local, okay? Because you're not going to be able to stretch those tissues as much with fat that's useful. And once that local comes out of that area, that volume, if you put a few hundred cc's of local, that's a few hundred cc's of fat you could have put in there, okay? That's very important to remember as well. That also plays into factors on revisions, especially with fat transfer revisions. I'm trying to, let's say, fix a dent in a certain place. That dent, whether or not that dent is expanded fully, has a lot to do with how much fat I'm able to place in that area. So if a patient says, well, why can't you do it under local? I can. And sometimes that's reasonable for a very small amount or not as significant. But when you're repairing multiple dents or large volume dents, you need to realize you need to get the optimal transfer to that area because some of the fat is not going to live. We all know that. The fat transfer viability varies from area to area of the body, but it may be between 30 to 70% depending upon individual healing characteristics, and also, what the actual area may or may not lend itself to, whether they've had previous surgeries in that area, whether they had previous traumatic deformities, how good the blood supply is in that area, and just certain areas of the body just tend to do better than others, as well as the amount of fat that you transfer. That has a factor in it as far as reestablishing vasculature to that free fat graft. All of those things are important. So remember that when you're trying to consider local versus general, okay? Yes, Dr. Hughes likes local, has nothing against it, but he wants the patient to be comfortable, and he wants you to only do one surgery so that you don't have to do multiple revisions, which is what I see almost every day. So that covers the liposuction, kind of the areas of liposuction, how you go about liposuction and the transfer and some of the realistic expectations, and then whether to do general or local. Like I said, I do a lot of revisions, so most of my revisions occur because, let's say, a patient is not satisfied with a more conservative result from the first round. Okay, that's very common. A person does a very conservative result. They may take out, a liter of fat, and they may transfer 500 cc's per buttock and say, hey, I did a great job, and they look better. That's true, they do look better, but a lot of patients don't want something that conservative, and so they're going to undergo this second round or third round of surgery to get what they want. So while I will not do something that is medically inadvisable, okay, for instance, I adhere to the 5-liter lipoaspirate limit, and I am going to transfer what I feel is reasonable before fat is basically spurting back out, causing a pressure kind of phenomenon there. I am going to try to maximize that, and that's the line you're skirting there when you're doing these surgeries. You're thinking to yourself, okay, what is the optimal amount I can transfer so that this patient won't have to undergo a second or a third or fourth surgery, and also won't have the risk or complications. So that's something else you need to consider, is when you're doing very conservative surgery, someone else is going to have to fix that. And it's not really fix is maybe a strong word, but somebody else is going to have to go back in there in the scar tissue plane, elevate everything else again, fix whatever things the patient didn't like the first time, and that makes the surgery intrinsically harder, and it is more complication ridden, and that's just the way it is. But that is my life of doing the harder surgeries, the revision surgeries, and I'm not complaining about it. I'd like to do a lot more primary surgeries, but I think patients really get to researching things when they've had one or two missed opportunities, okay? And so they're trying to figure out who gives them the highest probability of success, and I think that's why they come to me. There are plenty of good surgeons. I'm not saying that there aren't, but it is with the marketing especially out there and all of the things that you can read that have been obviously tampered with to produce one outcome or another, it's sometimes very difficult to determine, who can do what, and, who has the best results, who has the fewest complications. And you're never really going to know that. You're going to be basing that upon, information, some of which is either useless or totally biased. So try to think to yourself when you're looking at before and after pictures and videos, hey, let's examine, is this person, what type of surgery is this? Is this a very difficult surgery? What is this person saying to you as far as, methodology? How does he go about achieving results? What types of results does he get? What does the before look like in comparison to the after? What types of things does he do? Does he do a lot of revisions? How do those revisions look? All those things you should be asking. Does he manipulate the camera angle on his pictures? And I always bring that up because I can tell when people do that, and then it's almost hilarious to me. There was one person who wrote a review, he does something to the pictures or whatever. I take the absolute worst, most unflattering pictures of people on purpose. I take it flat angle so that you can't say that the buttock is, you're taking the before picture from above where, you can see that the waist is huge and the buttock is small, and then you see a lot of them take them from below, after, where the butt is huge and the waist is small. All of mine are very, very flat, and they're taking the same place, same angles, same chair I sit in, same room, same body positions. Another thing is having the arms, by the sides in the pre-op and above the head in the post-op, so that they no longer have bra rolls. Mine are all the same. I have the arms out to the side and pre-op and post-op. So you need to be smart enough to recognize that and to differentiate, something that is true from something that isn't true. So, and that always applies in all facets of life. Now, on the Brazilian butt lift, there's been a lot of talk of the safety of the Brazilian butt lift, and there's no question, 5 years ago, everyone was injecting into the muscle, okay, because there was only a theoretical possibility of getting a fat embolus. In other words, where you're injecting in small amounts, and you're injecting into the muscle. Even though the veins are farther away, we now know that there's something that goes on there where you get into the muscle. If you get into the muscle, somehow that pressure builds and it's able to get into some of the venous tributaries. Now, whether or not somebody's actually injecting into a vein or whether it's due to pressure, and some of these tiny little particles kind of build up and kind of eventually reach the lungs and develop something that is a fat embolus of some concern, no one really knows. But what we do know now is we should inject basically directly under skin. I developed a subdermal technique about 5 years ago, and the subdermal is you're basically putting a large cannula underneath the skin, and I'm looking at the tip of the cannula, so there's no way you can introduce fat into anything deeper than the muscle fascia because you're right under the skin. So you have skin, fat, muscle fascia, muscle, veins, okay? So all of this fat that I'm injecting now is way above the surface. Now, you're not going to have the fat embolus issue with that if you're doing that every single time. You're looking at the cannula and you're injecting the fat and you can see the tip of the cannula. That means you're so superficial, you're literally under the skin. The problem with the technique is you will never be able to produce the same results as the muscle because the muscle has a greater vascular supply, which is why we were injecting into the muscle before, is because it was always taught medical school and residency that you inject into the fat so that the fat can have a greater viability, okay, because the muscle has a greater blood supply. But now we're injecting into the fat and under the skin, and there's not only is there not as much volume into which we're injecting, but also that volume, it doesn't have the same blood supply. So there's no doubt you're going to be limited somewhat in the results. And then the question becomes, is there a greater risk of infection and fat necrosis as a result of not injecting in the muscle? And the answer is probably so, okay? I haven't really noticed that, and I'm nearing 2,000 on the new technique as far as the Brazilian butt lift, and I probably did that many or more with the old technique. So I haven't noticed the fat, I haven't had fat embolus either. I haven't had any kind of significant fat embolus whatsoever since 2015 when I changed the technique. Now, granted, in 2015, no one else was doing that, so they kind of looked at me like I was a fool, like, why are you doing this? Everybody was injecting into the muscle. But, when you have a fat embolus and you're thinking to yourself, well, everybody else is doing this, but I have to change something because, it's not worth it to have this theoretical possibility there. So I changed mine in 2015, haven't had any problems. I know some people and a lot of people who were utilizing the muscle technique into 2018, and that's when the ASPS finally decided, the American Society of Plastic Surgery finally decided to kind of make it, because of the large number of deaths around the BBL from good surgeons, from board-certified plastic surgeons. There was a paper that only surveyed about 14% of plastic surgeons, and there were 30-something deaths and 100-something non-fatal fat emboli. So that's, we're getting up into the hundreds of fat emboli just in one series, okay? So the question becomes, how many fat emboli are we really seeing? And those were, like I said, a percentage of board-certified plastic surgeons. So then you have, well, what's the total number of board-certified plastic surgeons? How many fat emboli do they have? And the answer is no one knows, but it's obviously much more than that. And then you've got to factor in all the cosmetic plastic surgeons, all the non-board-certified plastic surgeons, and those numbers may be 10 times the amount. So it was becoming an issue, and we now had enough data to analyze that, and so then we formulated a different approach, which I developed in 2015, but then was adopted in 2018. Like I said, I haven't had problems since 2015. No person is perfect, okay, and science changes with the times, okay, but it's important to understand why we initially were transferring into the muscle and why we thought that was the best and why we ultimately adopted a different approach, okay? So that's what I have to say about that as far as the evolution of standards and plastic surgery as a result of the experiential or the scientific kind of factors that we rely upon to kind of change those techniques, okay? So when you make a change like that, like I said, I was worried about fat necrosis increasing and infection because both of those things are more likely in something that doesn't have as good a blood supply, which is, there's no doubt you had less, not as good blood supply now that you were no longer transferring into the muscle. So I've kind of kept an eye on that, and I don't think it's any higher. I think the only limitation is you get a slightly less impressive result because before you were transferring into the muscle, and that allowed you to get more projection of the buttock, okay? But I think that the results are much closer than I would have thought starting at 5 years ago. Now, granted, some of that is because I'm constantly improving, and cheating in a good sense for the patient, trying to maneuver and get this tissue to expand in whatever way I can, while keeping that safe technique. And so, there are ways to massage it. There are ways to kind of break up some of the areas that are a little bit more stringent, okay, that have a little bit more integrity to them. So there are a lot of different things that I do, and sometimes you see me doing those things on the video, and I may not explain. It's not important that you understand every aspect of that, but there are definitely, certain plastic surgeons are going to get consistently better results because of the way they do things, okay, or the effort they expend during the surgery. And that's important to realize as well. So at this point, we've covered, liposuction, Brazilian butt lift, kind of local versus general, revisions, kind of what, maybe how to evaluate the plastic surgeon, the evolution of the procedure. Now, I have websites on, I have my regular website, which is thehughesplasticsurgery.com, and that has a lot of information, but I found that some of the information, is just getting too bulky, and so I have another website that's just Kenneth Hughes, Dr. Kenneth Hughes BBL, and that just focuses exclusively on BBL. It has a lot of Q&A and things like that, and I make these things so that, patients can kind of go to those and not be overwhelmed with, I have facelift and neck lift and rhinoplasty and all these other things. So I try to limit that. Now, I've been an author in multiple publications on all kinds of different plastic surgeries, and while I like to share that with you, I agree you sometimes are inundated with all these facts and it's too much. So I have that Kenneth Hughes BBL. I also have another website that is kind of a simplified form of the Hughes Plastic Surgery, drkennethbenjaminhughesmd.com. I just think that it just has less information on it, but it is... I've got it compact, I've got kind of a sampling of the various surgeries to do, like mommy makeover, tummy tuck, things of that nature. Basically the whole gamut of plastic surgery. And I just touch on slightly different topics. But like I said, that HughesPlasticSurgery.com is kind of the go-to one, and it just has so many different things. The other website I have is the drkennethhughes.com website. Now, I made that one for technology and for plastic surgery education and kind of plastic surgery news. So things that develop in plastic surgery, kind of... ethical conundrums or innovations in science, technology. Sometimes I'll add some of those things there, some topics that aren't discussed as well in other media, or perhaps things that aren't as popular I'll put in there. Sometimes there are things that I don't even do. I'll just review a certain thing and I'll say why I don't do this or don't do that. I use a product called Body Tight and stuff like that, and I think that's a very good product, has some good science behind it, and I've noticed good results. And I may review that, and then I may review another product like Votiva. But anyway, it has, all these websites have different uses for different patients seeking different things, and I think they're all educational by nature. So that's why I have those. I will continue with this video series. Hopefully I won't be as verbose as some of the other ones, but we'll continue with the next topic soon.